Hi, it's Michael Hill here from University of Calgary and Calgary Stroke Program, and I'm here to talking about the Tempo 2 trial, and we're going to just go through a mock consent procedure so that people can see how one might take a consent for a patient potentially eligible for the trial. And I have with me Amy Yu, who's a stroke fellow, and she's going to pretend to be the spouse of a potential patient for the trial. So we're going to go through it from here. My name is Dr. Hill, and I'm looking after your husband. And I just wanted to explain what's happening. You know, he's not too badly affected. It's just a minor stroke, but I want you to understand what that means. So there are two different types of strokes. There's ischemic stroke and hemorrhagic stroke, and the most common is ischemic, and that means there's a blocked artery in the brain. And we see that on his CT scan. We can see there's a small artery that's blocked. It's only a small artery, and that's why he's only mildly affected. So he's not fully paralyzed on one side, for example. So the usual situation in this kind of scenario is we would tend to manage patients like your husband fairly conservatively. We treat him with medicine like aspirin. He might be admitted for a short time in the hospital, and the expectation is that he would do very well with just conservative treatment. However, in the last several years, it's become clear that patients with minor stroke with proven blocked arteries are the ones who are maybe at the highest risk of deteriorating. So we see that about a third of people actually get worse in the first 24 hours after this scenario. And so we're trying to understand, is there a new possible treatment? So whereas the usual treatment would be to give him a medicine like aspirin, what we're going to propose is to give him a medicine to unblock that blocked artery. So those are called clot-busting medicines, and we use them routinely when people have more severe stroke or come into hospital quite early after the stroke onset. So we're involved in a study called the Tempo 2 study, and in this study, patients are randomized to a new treatment, a clot-busting treatment, or to usual care. So randomized means that essentially it's a flip of a coin. Half the patients will be assigned to get the new treatment, half will be assigned to get the control treatment. And when you agree to be in a study like this, you're agreeing to be randomized. You don't get to choose which treatment. It means essentially, in this case, it means a computer is going to decide, but it's going to be a random treatment. So what would normally happen is that if you agree that this is an appropriate thing to do, he would get randomized in the study, and then we would institute the treatment right away. So he would get a new treatment. This clot-busting medicine is given as an intravenous injection, so it's really straightforward. It's just a one-time dose, and then it's done. And then he gets the usual standard of care. If he's randomized into the control group, he would get aspirin and regular standard of care. And the one thing I can promise you is that we would give everybody the best standard of care over and above what he has, what happens to him. So this is what we would normally do. So what are the alternates? So the alternates are that we would treat him conservatively, as I proposed. We would do the normal routine thing. We would not give him a clot-busting medicine. And this medicine is really only available in the context of this trial. We wouldn't normally use this medicine for this kind of scenario. Key things about this scenario is that, you know, even medicines like aspirin, which we would use, have been proven in trials like this. So in the past, patients, you know, like your husband, had received aspirin or a sugar pill, a control, and now we know that aspirin works, so we give it to everybody. So this is the process of doing clinical research. So important things about research to understand is that all research is voluntary. So you don't get paid for participating in research, or, you know, your husband doesn't get paid. And if something happens, or if you change your mind over the course of the study, which involves a 90-day follow-up period, if he wants to withdraw from the study, it's okay. We accept that happens. Now, most people don't, of course, and they follow through, is because it's just routine care at that point. But it is voluntary, and even now, we would still provide your husband with the best care. It's whether you decide to participate or not. You don't get paid for participating in a trial like this one. Patients, You know, in general, we like to think that if patients do better in clinical trials because they're followed more closely, and if you look at across different disciplines, whether it's cancer or heart disease or stroke like this, we think that patients involved in clinical trials tend to do better, but we don't know specifically if your husband's going to benefit or not. He might not benefit from this. So an important thing is, could he be harmed, right? And these new clot-busting medicines do have side effects. They're more powerful than aspirin, and you could think of them as like a very powerful blood thinner. So the risk is bleeding. And patients who receive these medicines can bleed. They bleed from their IV sites, or they could bleed internally in the stomach or something like that if they had an ulcer. And most seriously, they could bleed into the area of stroke. Now, those side effects are very rare. Right? It's uncommon that we would see that, and there's been a number of studies with this medicine that shows that it's uncommon, but it's not a zero risk, right? So that's a really important consideration. If somebody does have a hemorrhage, it can be very serious and sometimes fatal. A key component of this is that you know, we've done a pilot study, and it looks very promising for this medicine. It seems to show that patients' arteries do open up with it, and they do better when that happens. And so this is why we're hopeful that this will be a positive thing. But of course, because I don't know what group your husband would be allocated to, we don't know whether he would benefit or not. But certainly, the process of the trial when we come to the end is others will benefit. So if we show, for example, that this medicine is a good one and that we should be using it routinely, then we make that information available to everybody around the world, and then try and make the drug available for all patients, just like your husband. This doesn't change the standard of care. So when we do clinical trials, we say that we're going to give everybody the best standard of care we can. And then over and above that, we're saying, if you participate in this trial, you may get a new therapy that may be beneficial, and we're trying to improve the care overall. The final thing that we do with all studies is we ask you, on your husband's behalf, to sign a consent form to say that you understand what's happened, and you've had a chance to field questions and understand what's going on. A consent form doesn't waive any legal rights. It's not a contract or this kind of thing. It is just simply a way of formally documenting that we had this discussion, you understand what the trial's about, you've had a chance to ask questions, and you think it would be an appropriate thing to do. Does that make sense? And do you have any questions?